pink clothes?
And pink. Yeah, I know what is happening inside the OT. Yeah. So it's, I think the meeting is getting ready.
So we are live onto YouTube. Okay.
Yeah. So before we start this session, I would like to humbly thank everyone for making this masterclass series a huge success. Both me and Dr. Jay are extremely grateful for this appreciation. We have had more than 1 lakh views on YouTube, and we hope we continue to meet your expectations with regard to the topics and as well as the content. So I thank Dr. Jay, who, in spite of being so busy with his clinical and surgical work, and in spite of having so many travel plans scheduled during this classes, he has taken classes from the car while he's commuting to the airport and from various places like Chennai, just to make sure that we are consistent in our efforts. And today's topic is oocyte retrieval, which has been requested by many people. I think, as we all know, that it's a very important topic for all infertility specialists, though it's a very simple procedure, but doing it the right way with properly timing the procedure and giving minimal anesthesia is something which everybody wants to optimize. So the safety of the procedure itself, though it's very simple, sometimes can get out of hands. So I welcome Dr. Jay to deliver this lecture, who has come in between the procedure to deliver his talk, and he will go back to the operation theater to finish his surgery. So over to you, sir.
Yeah. See, I want to clarify two things. Okay. Ovum pickup, though Madam mentioned it is a very basic procedure, please understand ovum pickup is classified as an operation theater procedure, medico-legally. So you are supposed to follow all precautions which you follow for doing an OT-based procedure. Okay. It is not an OPD-based procedure. It is an OT-based procedure. That is the first thing. Second, I have just got a model of a uterus here. Okay, so I just wanted to show this ovum pickup, how it actually, what is the logic that we have to keep in mind. Okay, so we all know that if we see here, this is where the vagina is, correct? And through the vagina, the probe will go inside. Okay, so whenever the probe is going inside through the vagina, the probe has to go at the level of the fornix. That is something which people have to keep in mind. Lots and lots of times people don't keep the probe at the fornix. That is a mistake which people do. Okay. Second, if you look behind, see this, the distance between a stimulated ovary and the fornix is still present. Okay. So what you are supposed to do is, whenever your probe is in the fornix, push it in the fornix. So the distance between the ovary and the fornix should be absent. That is the actual logic of doing an ovum pickup. Now let's assume the ovary is attached to the uterus. Okay, then your needle is going to go through the uterus basically, and when it goes through the uterus or when it goes through the cervix or whatever it is, then God has gifted you with an ovary which is already attached to an organ. Okay, but your probe should be attached to the organ through which the needle is going. That is the most important thing which you have to keep in mind. Okay, now second thing, see, there is nothing that patient has to be kept in head high position or a patient has to be kept in head low position. Please remember one thing, normally the location of the ovary is just going to be under the pelvic brim, under the level of the sacral promontory. Okay, so even a stimulated ovary as such is going to lie in the space between the rectum. So it is going to be lying down somewhere here. Okay, even a stimulated ovary will be lying down in this space. So that makes your life very, very easy. But let's assume an ovary is upstairs. Ovary is above the pelvic brim. It is very, very easy. Just put your hand, palm, and compress at the region of the lateral gutters. When you do that, automatically due to the pedicle of the ovary will come back inside the pelvis. You don't have to do any fancy maneuver before initiating your oocyte retrieval. Okay, just press your palm on it. It can also help in stabilization of the ovary, and it will also get the ovary down. So that is something which you have to keep in mind as a logic is concerned. Okay, fine. The pickup needle is very standard. All of us are using the 18 gauge pickup needle. Okay. Second, the pressure pump, the oocyte aspiration pump, okay, is also very standard. Normally, people would standardize their pressures between 100 to 150 millimeters of mercury. Okay. More pressure than that, more higher pressure than that, let's say pressure 300, 200, 400 can cause the cumulus to lyse inside. Okay, because it is like a mechanical pressure, so it can cause the cumulus to lyse inside. All right, so don't keep the pressure more than that. Just keep it between 100 to 150. That is standard. One more rule, just this is the most important take-home point of this lecture. Okay, once you put your foot on the aspiration pump, don't take out your foot till the egg pickup is completed. I have seen countless people who have come to me for training and all these things. They aspirate one follicle, foot comes out. Okay, don't do that. Just keep your foot there. Even if the needle is inside an aspirated follicle, it will not compress further. But get into a habit of the foot permanently being on the aspiration pump. That will really ensure that even if your needle accidentally enters a follicle, okay, the follicle will get aspirated out. And that is something which you should probably learn and take home as a very important part of this lecture. All right, fine. We never follow a system where one follicle aspirated in one tube and tube sent inside the laboratory for examination. By doing that, no, you will be only able to do one pickup in an hour. Okay, if you have 10 follicles, you will do one follicle. Person will go inside the laboratory, or anesthetist will come and kill you. Okay, I am going to show a live egg pickup which we had done today morning. Okay, I know there are many people who will speak behind my and Shilpa madam's back. Themselves will conduct coaching classes, take money from people, and will tell people behind our back that we are doing this for marketing. But I'm going to show it officially and live. A live egg pickup in 3 minutes. Okay, the max time it takes is 3 minutes when you have a normoresponder giving 10 to 12 oocytes. Okay, we are going to go to that a little later. Okay, before that, I want to finish what I had thought as I came out of the OT. Okay, after all these things are done, after your egg pickup is done, just one important point you have to remember in cases of endometriosis. Even if you are the world's best fertility specialist, which all of us are, no? Every fertility specialist believes that they are the world's best. Okay, so what typically happens in that situation is people will guide you that you pass the needle without activating the suction pump through the endometriotic cyst. For God's sake on earth, don't do that mistake. Okay, because you are going to cause seeding of bacteria from the vagina in the endometriotic cyst. The minute that happens, within a few days, the patient is going to end up with fulminant oophorytis. If any one of you has never seen a case like that, kindly come to my hospital. Every week we operate one. Okay, every week we operate one. All right, and it is, if you want challenge in life, then this is a challenging case. Okay, this is the worst case you can operate. Fulminant oophorytis post egg pickup. Okay, so keep that in your mind. Second, there is no role of doing double aspiration. That means once you have aspirated a follicle, many people say that because once your follicle is aspirated, it will form a small hemorrhagic cyst inside. So go and aspirate that also. There is no role of re-aspirating an aspirated follicle. It will only add to your confusion. So don't do that. Okay. Finally, by saying this, now I will finally go on to that video. Okay. And I will demonstrate the live egg pickup, which we did on the today morning. Okay. 1 minute. Huh? Shilpa madam, see if the screen is visible.
Yeah.
Yeah. I think this also has audio. Let me play the audio.
Audio is not heard.
Acha, audio is not heard. Okay. So see, this is your normoresponder patient whom we have aspirated today morning. Okay. See that needle coming in. Can you see that needle coming in? Now try to align this needle. Can you see this? Try to align this needle to come in the center of the follicle there. Okay. Once the needle comes in the center of the follicle, can you see that? It is in the center of the follicle. The aspiration is super fast. See this. I will try to pause it when it is in the center. Yeah, see, this needle is right in the center of the follicle. So once the needle is in the center of the follicle, it will auto aspirate the contents. See this? And at the end, see, we are rotating it. Can you see that? We are rotating it inside the follicle. Just rotate it inside the follicle. Sometimes there could be a sticky cumulus which is not going to come out otherwise. The best way to remove is just rotate it inside. Okay. Also remember, there are going to be people who are going to use different types of pickup needles. There are people who say that the sonolucent tip is very important to use. There are people who say that the biopsy guard has to be absolutely parallel to the direction of the probe. All that is good, but then I guess once person develops enough experience of doing an oocyte pickup, all those things really then stop mattering. Okay. So don't get into those type of fancy habits. Otherwise, you will make your life difficult. You can see a vessel here. See, this is the vessel. I'm trying to indent on the vessel deliberately. I'm not wanting to go inside. But if in case there is confusion, you can add a Doppler and you will see the vessel. So obviously, you don't want to do a aspiration of the vessel. So just withdraw your needle from there. Okay. One side done. Now see, this is the ovary which is high up, which I was mentioning. Correct. So what you do, you put your palm over the abdomen and see that ovary comes little down. Automatically, once that ovary comes little down, your job is done. Okay. From the probe, you are going to be able to easily aspirate. See that your needle goes right in the center. You will be easily able to aspirate. See, remember one more rule. My needle never goes out of the ovary once inside the ovary. It doesn't come out and creates multiple holes on the vaginal fornix. The vaginal fornix has a single point entry, as a result of which the bleeding which occurs post pickup is zero. And remember, we do pickups under local anesthesia plus sedation if the patient requires and requesting for sedation. Otherwise, this is a lady who is clapping at the end of this video because this is done under local anesthesia. Okay, absolutely local anesthesia. She is beautifully cooperative. You must give 10 cc of bupivacaine plus dexamethasone, okay, in the posterior fornix of the vagina. Okay, and once you finish, see that you will be able to knock out and come out. What will happen is, as a great thing, as at the end of these pickups, what will happen is the patient is sitting in front of you once the pickup finishes. Okay, and she will be ready to go home in the next 20 minutes. She, in fact, more than 80% of our patients will don't even miss office on that day. Okay, we are little poor people, so we treat a lot of working class women, and we deal with a lot of other people who are severely committed to their professions. Okay, and they have to attend some meetings or whatever on the day of pickups as well. Everybody can go if you are giving local anesthesia and patient is able to tolerate it. If sedation is given, then patient is to be kept in the hospital for 3 hours. But if the patient finishes in local anesthesia, patient will go home in 20 to 30 minutes. That will allow us to have more beds to accommodate more fistula patients. Understanding? But that, yeah, of course, that's a joke. But this is something which you can keep in mind when you are doing an egg pickup. Now, important. Please, I will tell about that local anesthesia again. Just put a posterior. What is it? Posterior speculum in the vagina, sim speculum. Okay, just put a posterior speculum. All right. Don't grasp the cervix with the Alice. Don't need to do that. Patient will have little pain. Okay, put the posterior speculum. Take the 20 gauge needle. Okay, 10 cc to 11 cc of local anesthesia, bupivacaine, with 1 cc of dexamethasone. Okay, the posterior fornix will swollen up like how it swells up when you are doing hydrodissection in vaginal hysterectomy. Understanding? And after 2-3 minutes, okay, just 2-3 minutes, just do some time pass with the patient, measure that stupid Doppler of the follicles, impress your patients with all these things. Look, very good it is, and all these things. In that time, local anesthesia would have acted. Okay, once that local anesthesia would have acted, then you do. Okay, and as I mentioned, if you saw my pickup, the thing is, once the needle goes in the ovary, in one ovary, you can withdraw it till the tip of the ovary, but don't remove it outside. Your vaginal puncture should be a single puncture, if you can possibly do. Okay, and when that happens to you, the pain which the patient experiences is virtually zero. Okay, at the end of this procedure. Okay, what will happen if there is bleeding from the vagina? See, normally your bleeding is going to happen because your needle has punctured through a vessel and it has gone inside the ovary. So it will come as a bleeding outside. Again, put that posterior speculum, take an Alice and just grasp that bleeder with the Alice for approximately 5 to 10 minutes. The minute you do that, that bleeding will also stop. Okay, let's assume that there is some oozing which is coming from the cervix. Simplest tip I will give you. Nobody, it's not mentioned in any textbook. I don't have any stupid RCT for all these things. Okay, take a gauze piece, take Lox jelly on the gauze piece. Take a gauze piece, simple gauze piece, and take Lox ka jelly, lignocaine 2% jelly on the gauze piece, and push it in the posterior fornix. Dhakka. Just put it in the posterior fornix. It will cause compression, and because of that Lox jelly, it is little like a gel sort of a thing. So that minor oozing will get arrested there only. Okay, this is what you can try to do when there is a minor oozing which is coming from the vagina. Okay, we don't catheterize these patients. We ask them to empty their bladder before they come to the pickup room. Okay, normally in more than 60% of the patients, unfortunately, I am also an embryologist. So when pickups are happening and if I am free on that day, I try to look at the count of the cumulus, how many COCs we have obtained from the pickup in between the two pickups. Okay, so one assistant will give that Lox, will give that anesthesia in the posterior fornix. That 2-3 minutes time pass they will do. By that time, I would have counted the previous patient's COCs. Okay, so that is what the routine which I follow. People who have come to my place, many people from the group has already visited my place and they have seen me doing the exact same thing. So yeah, one more thing. I don't really prepare an egg pickup patient as if they are going to undergo bypass surgery or transsphenoidal resection. Understanding? It is a very basic procedure. Don't really load them up with gowns and unrealistic sterility. People like not even that smallest of the lactobacilli should go anywhere. No, you don't really need to do. I mean, you can. It is shown in movies, but in real life scenario, if you are really, people are laughing. I know, but if you are why? It's a fact. But if people what? Why are people laughing? I have been called once upon a time to do an emergency egg pickup. Okay, can you imagine? Egg pickup is also emergency. Okay, because both the ovaries were posterior to the uterus and the world's best IVF consultant could not access it. I could not find the patient only. There were so much drapes which were kept, So it's a very basic procedure, guys. This is something which you need to do day in, day out. Don't laugh like this, guys. Come on. I will also feel like laughing, okay? Yeah, but I just wanted to tell you that, okay? And that is important. Okay, even if you are doing one pickup a year, okay, don't dress them up. I mean, so much. We don't even use leggings, to be honest with you. Okay, we just use a whole towel. That too, if the nurse has made a mistake and put the whole towel. Okay, otherwise it is really not indicated. Okay, I hope, I can't be more clear than this as far as the neck pickup is concerned. So your ophthal husband is laughing, but yeah, it's fact, right? We prepare for a pickup. Somebody has come back to the moon with the oocytes. No, it is so stupid. And yeah, the vaginal preparation. What do we do in the vaginal preparation? We clean it with normal saline. Okay, gauze piece, normal saline, and take the gauze piece out, because the commonest mistake post egg pickup is gauze piece goes with the patient. Okay, and it comes out on the day of embryo transfer. So don't do that. Okay. But yeah, apart from this, the session finishes and I shall be happy to answer questions.
I will ask. Okay. So, bedded in vaginal tablet the previous night, or Clinton forte, something like that, clindamycin vaginal tablet?
No, we don't do that.
But do you use the probiotics throughout the IVF stimulation? Have you?
Yeah. We use probiotics throughout the stimulation.
Okay. And bowel preparation, do you give them enema or do you give them Dulcolax the previous night?
Nothing at all.
Okay. So when do you?
Nothing at all.
Yeah, when do you use general anesthesia apart from patient requesting or patient being sensitive?
Very, that very obese patients, no, madam. Very obese patients, in that only.
Okay. And have you had any patients with ovarian surface tear, which you have converted into laparoscopy and sutured the ovarian surface or coagulated?
I mean, around 8 years back, we had one patient from some other consultant got to my hospital for that. So at that time, that consultant was doing egg pickups at my unit only. Okay. And that time, something like that had happened and we had put in a laparoscope and sutured it. So far, I have had total, in my experience, I have got 6 patients so far. Okay. No, 7 patients, sorry. So far, where the needle has gone right through the internal iliac vein. Through and through, understanding. And it has caused a retroperitoneal hematoma. Okay.
Internal iliac vein or external iliac?
Sometimes internal, sometimes common iliac. It depends, no, madam, how the bifurcation is, right? We can't really predict that. And it causes a hematoma there, madam. And I have done a laparoscopic surgery for treating that hematoma. But very rare, huh? I mean, not common.
Okay. And have you had any intractable vaginal wall bleeding, which you had to like take a suture, take a bite?
Not yet. If you follow the single puncture technique, you will not have that.
Okay. In your OPU OT, do you avoid perfumes or nail polishes, or do you tell the patient not to use the deodorants? Or
even if the patient doesn't use the nail polish and deodorants will come, who will stop these girls in the OT from not using? They have two boyfriends at one time. Okay, so they have different nail polish on all fingers. Okay, how you will stop them, madam? They don't listen. Okay, they don't listen only. Even if you change the staff, the orientation to the new staff is you wear as much as perfume and go. Okay, so I think all these types of things, okay, they are important. I know people will talk big things about VOC and VOC meter and all that nonsense. One day when we talk of VOC meters, no, I promise you, next day morning, pan India VOC meters will be up for sale. Okay, because it is that bad. But any which ways, I personally think that all that doesn't really play a role. I think Dr. Padma Priya, who is our colleague in Chennai, she has visited my IVF laboratory in her for 10-inch heels. Okay, big, and she was wearing all beautiful clothes when she came to my hospital. No changing. Okay, no changing of clothes inside the laboratory. Even I don't change. Okay, I know I am going on record on public. If you don't believe me, bindas, ask to Dr. Jatin Shah, sir. I am idiot, but sir is not. No, sir is such a great guy. He is like my father. Even he does not really insist on doing all these things. Yeah, that is very good. That is very good if you want to, I told no, if you want to make Ovum Pick Up feel like cardiac surgery. Oh, anesthetist is also wearing 25 gloves and giving anesthesia. Okay, if you want to do all that, but otherwise it is not needed.
Okay, PP madam is online. Can you unmute her? By then I will ask you a few more questions. So do you use only powder-free gloves or powdered gloves are okay, you think?
It is better to use powder-free gloves, madam, especially in the laboratory. Okay, especially in the laboratory. Ovum pickup also better to do with powder-free gloves. But if you have if there is a place where there is no such things available, you can use powdered gloves and put sterilium over it. No powder will come out.
Okay. And do you use culture media inside the vagina to cleanse it? Is it required?
No, I only use normal saline, madam. No need to waste your culture media over somebody else's vagina.
So you didn't.
Why you are laughing?
You can't be like this. You have to be serious. It's a very.
No, it's true, no? Shilpa.
No.
True.
Yes,
What
I'm
he's
speaking
saying.
the truth, right?
Yeah.
You can't do this. This is a very important section.
Yeah. Shilpa madam, a small question from me. Jay, do you darken the operation theater? Do you dim the operation theater lights or pick up the oocyte in dark? I mean, do you make
Why?
in dark? I'm just asking. I know there are many people who are doing it. That is why I'm asking. Does a tube light or an operation theater light harm the oocytes?
You, how will it harm, sir? It is oocyte is inside somebody else's ovary.
Array, when it is aspirated into the tube, I am talking.
No, but you are examining that oocyte under machine light. No, that light will not harm or what?
There are people who are darkening the theater. That is why I'm asking you.
My God, no. I mean, I have never heard of it, sir. Don't know.
Okay, so let us quickly finish, no, please. So biopsy, you didn't switch it on the ultrasound machine. You just went ahead and directly did the.
We never do it. Yeah, never switch it on.
Yeah, but what if you have a new assistant or somebody new who is doing the procedure? I mean, would you recommend it for the learning curve where they know exactly in which part the needle is going?
See, honestly, the best way to learn egg pickup, oocyte pickup, is by routinely doing transvaginal ultrasounds and locating the bladder, uterus, and the rectum. Okay, all three things simultaneously in a single plane. So when you do that, your automatic orientation of the hand and the probe becomes very good, right? And then probably one doesn't need biopsy guard, I think.
Okay, so do you use a single lumen needle or double lumen needle?
I use single lumen, madam.
Okay.
I never flush. I wanted to tell that thing. I never flush the oocyte. Never.
Okay, so your pressure is always between 100 to 150.
Yeah, 100 to 150 is standard.
And if there is any blockage in the tube with a clot or blood?
So just reverse it. No, the place from where it is coming, just use a 20 cc syringe and push it. See, I'll give you an example. What happened around 5 days back at one IVF center in Ghatkopar, one of our friends' places. Okay, so their oocyte aspiration pump, no, it suddenly stopped working. Okay, so the anesthetist called me. Are what to do here? Now it is suddenly stopped working. Now what? Correct. So the best way in which you can do it is take an artery forceps, okay, and just clamp your tubing. Just clamp the tubing. Behind that, take a lower lock syringe, 50 cc. Like how we do that manual vacuum aspiration, like that. Yeah. Blow it up. Take that 50 cc syringe full up to 50 cc and then just release it. Just release the artery forceps. It will automatically give you 100 units of pressure inside and 1-2 follicles will come out. Okay. Just repeat that if the machine fails. Something like this may happen to people, you know.
So follicular flushing, you don't believe in it? I mean, you don't do it?
No, we don't really do it because by doing follicular flushing, you are not going to get additional oocytes. A better option is you can just rotate the needle at the end of the procedure and that will take out the cumulus from there.
Okay. So if at all, if the ovary is not accessible and if it is behind the uterus and with all your manipulation, you still aren't able to bring it close to the wall. So you go, which is better? I mean, going through and through the cervix or going through and through the uterus, avoiding endometrium?
If there is no fresh transfer, then do what you want, right? If there is no fresh transfer, then do what you want. If there is fresh transfer, then also honestly, it doesn't really matter. Because your fresh transfer is going to occur after 5 to 6 days when you have blastocyst. Understanding. By that time, everybody will heal. That entire tract will heal. So honestly, it doesn't matter. But we try to teach people and all our assistants that, you know, don't injure the endometrium, at least spare something, you know.
So do you put a speculum, hold the cervix with the alleys and try to manipulate it from below to make sure that the push the uterus up and then bring the ovary down with all your assistants' help?
Just put a palm over the gutters, lateral paracolic gutters. Ovary will come down, madam.
Okay. And what if there is a hydrosalpinx or an endometrioma? What do you do in such situations?
See, as I told, one of the best things in endometrioma, especially, and hydrosalpinx, both the things, the first thing is don't be overconfident about your skills in that case. Okay, because the best guy can end up with the worst complication. Okay, that is the one thing. Second, when you are aspirating, see, this is a fixed ovary. Endometriotic ovary will not keep on turning through the pedicle. It is already fixed, okay, at some location. So what is going to happen is try your level best to avoid the cyst and go peripherally and pick up. Sometimes you may not enter into the corner of the center of the follicle. Even if you enter in the corner of the follicle, pick it up. That time, don't keep your ego that I will enter only in the center, otherwise I'll not enter. All those things to be avoided in endometriosis. Please avoid the endometriotic aspiration of the cyst. Okay, please avoid that. All right, and that should help.
Yeah. So if there is any pelvic infection which you come to know on that day, like if you notice any white discharge or anything, or fungal infection, so how do you manage the case?
Yeah, you can use douching, okay, in the vagina with hydrogen peroxide, 2 drops in 100 ml of normal saline.
Okay.
But don't use betadine if possible.
Okay. And what about this external iliac, internal iliac veins or common iliac veins if you accidentally puncture? Or would you want to give a tip to all the members who are watching how to avoid
I said you should add a Doppler when you are in doubt. But remember one more thing. The vessel wall is thicker and it is pulsatile. Okay. Follicles don't pulsatile. Follicles are not pulsatile.
Sometimes the vein may not be pulsatile, and also they may not have Doppler in their facility.
Yeah.
So you are doing
turn the probe. Simplest, one more simple thing, just even if you don't have Doppler, just rotate the angle of the probe by 90 degrees. The vein will appear like a hypoechoic dundee in the tangential form, in the tangential manner. Follicle will stay like follicle,
Okay. And what if there is an ectopic kidney, like a pelvic kidney?
Very common. We have done we would have done 400-500 pickups like that. Ectopic kidney, absent uterus, that MRKH patients whom we create this new vagina, no, very, very good. If you have any complication in that, contact me. I will guide you on video how to do laparoscopic pickup. Don't eat your head in that thinking that I want to do vaginal pickup only, because what typically happens is, remember, artificially formed vagina will have adhesions on both the sides. Okay, it will have bladder coming up, it will have bowel coming up, then there will be vagina, and above that is the ovary. Okay, so if in case there is any difficulty, if your probe is not going straight onto the ovary, and if there is difficulty, don't break your head. Just do a laparoscopic pickup. Simplest thing on earth to do. Okay, much more easier than this transvaginal thing. Okay, you don't really have to do so much manjan also. Okay, and it is the best thing to do in my opinion. Okay.
And so after how many hours after trigger you do the OPU?
Between 35 and 36. But till 37 also it is okay. Nothing really happens.
Okay, so we'll have another session on this laparoscopic pickup and transabdominal pickup. Okay, so somebody is asking in the this thing. So do you do single puncture for both ovaries? So that means vaginal single puncture, but ovaries, I think you have to take 2 punctures.
Separate ovary, you have to puncture separately only, no?
So suction still has to be maintained even while you are not.
Yeah. Even if you are, you are changing the tubes and all these things. Some people have that very irritating habit of telling the nurse when that follicle flow is coming, no, inside the tube, inside that. Inside the tube which you are collecting, coming, more, slow, drop. Ayyo, it's so irritating. If instead of drop, she has said coming, they will kill each other, So stop. If you have new staff, you can't laugh like this, Shilpa madam, okay? If you have, what? It's a fact. There are people who do that, right? So if you have like brand new stuff, people are laughing on me. It's okay.
Okay.
Why?
Yes, I know people do.
Yeah, people do. I've seen that.
They see coming, drop.
Yeah, and then drop, and people fight with each other.
Yes.
I've seen people slapping.
But it is more out of the habit of that hysteroscopica cannula, na? Hysteroscopica irrigation. they have to have a cutoff. Na, kya re, khatam ho raha hai, pani khatam ho raha hai. So that is that mentality.
Yeah, yeah, but I've seen why to slap people if instead of drop, it is coming. It's all the same.
So that the vacuum is not lost. That is the concept behind that.
No. Vacuum cannot be lost once you are inside the ovary. Vacuum can be lost if you are in the vagina, which you will know, right? Oh, you're in the vagina. You don't need coming from the vagina.
I know the background is the hysteroscopy mentality. That's what I'm telling you.
Stop. One more important. Stop, sir, please. Okay. A post procedure. What is your advice? Do you give antibiotics? Do you give antibiotics for 5 days? Do you give antibiotics?
No. Post procedure, we give one thing to the patient. If we have aspirated more than 12 follicles, we will give them cabergoline 0.25 mg for 3 days. Okay. And we will give them cyclopam because when the ovary is undergoing spasm, that can cause a little amount of pain in the next 3 days. So we give cyclopam tablets, but we don't give antibiotics to these patients, madam.
Okay, less than 12 follicles, what do you do?
Nothing, just ask them to go home.
So you don't give antibiotic shot at all for these patients, even intra?
No, one shot on the day of surgery. During the OPU, maybe 15 minutes prior to OPU, they will give a test dose of augmentin and give one IV augmentin. And after that, it is done. There is no more further antibiotics, madam.
Okay, even if you have gone through the endometriotic cyst or hydrosalpinx or anything, you still don't give antibiotic? No? Okay. Yeah.
It will not help you, madam.
Yeah, I think we have covered most of it. Thank you so much. I think you have to get back to your OT. Thank you so much for a wonderful session.